Good afternoon. My name is Micaiah Salisbury, and I am the Consumer Empowerment Program Officer here at the New York State Health Foundation. I'd like to welcome you to our online discussion. Today's webinar will focus on strategies to improve patient engagement, access, and equity to telehealth services. Our presenter today, Shoshanah Brown, is the founder and CEO of AIRnyc, a community-based organization with an established reputation for employing community health workers to assist patients in navigating complex, fragmented, and often intimidating care systems. Before we get started, I'd like to go over a few housekeeping items. This webinar is being recorded. A recap with a link to the recording will be circulated afterwards. Video and audio are disabled for attendees. So if you have any questions or comments that you'd like to share with us, please type those in the chat box throughout the event. After the presentation, I'll read those questions aloud from the chat box to Shoshanah. For hearing impaired attendees or anyone else in need of live stream captioning, please click on the closed caption icon at the bottom of your Zoom screen and select Show Subtitle and/or full transcript options. All right, so I'd like to jump right in. I know this is with the explosion of telehealth this past year, plus a lot of us have really been focused on these efforts. And with New York State having seen approximately 130-fold increase in telehealth usage since the start of the pandemic, its expansion has certainly highlighted access issues with rural, low income, and people of color experiencing more barriers and lower levels of utilization. We know there are a number of barriers that limit this access, such as lower digital and health literacy, discomfort and confusion, and lack of access to internet connectivity. So it's so important as telehealth continues to evolve that we ensure it's designed in a way that benefits everyone and promotes health equity. And I'm so grateful to have and welcome to Shoshanah to share her experience, as well as some actionable steps we can all take to ensure telehealth narrows disparities and doesn't leave marginalized patients behind. So Shoshanah, I will turn it over to you to share with us your experience and your wonderful insights.
Thanks, Micaiah, for that introduction. It's a pleasure to be here today. Through our work at AIRnyc, we have learned a lot about the barriers to access to health, first and foremost, the conditions that we all need to thrive and be healthy. We've learned about barriers to healthcare, which is the set of services that we all understand that to be in medical settings. We've learned a lot about the barriers to social care, which are a component of that first sort of list of conditions. And more recently, through our work in COVID-19, we've learned a lot about barriers to telehealth, which we see as really just health care, another pathway to health care. So the work that we do at AIRnyc is through community health workers. And really what we're trying to do is show up for people who struggle with access to health and to health care and to social care in general. Through COVID, though we were aware of the digital divide and the disparities in access to all of these kind of resources before COVID, through COVID, as we all know and have heard, and read every day and all day long about the disparities and that were exacerbated during this period. My team at AIRnyc has worked very, very judiciously to understand those specific barriers to telehealth access, understand what we mean by digital divide in New York City, and work with partners, community partners, health system partners, payers, to try to address and mitigate those barriers. I can speak to the period of early COVID where, March 16th, we all at AIRnyc flipped to a remote virtual care model, connecting with the patients with whom we used to connect in person and through home visits, now digitally and remotely. That was a really big pivot for us. And as a community-based organization, we had to stand up a lot of sort of even basic technology quickly to do that for our staff. And we learned that, in those early days of the crisis, the issues that were a struggle for the patients we served, the people we served before COVID, were only going to be worse and worsening. So most immediately, our focus was on food security, was on access to essential prescriptions and medications that people already had, was on how do we care for people who have multiple chronic conditions but are now unable to go in for treatment in person. And through our partnerships, including with safety net partners such as health and hospitals, we quickly ramped up pathways to connect. And one of the things I want to do on this call is define telehealth broadly, including the use of the telephone. Let me take a pause there, Makaya, and see in which direction you'd like to go on any of these topics. I can also, kind of dive in and talk about, what those barriers look like and what we heard from people on the ground about why they were having difficulty accessing, or, let me hear what you think the audience is most interested in exploring.
I think that if we could elaborate on kind of what you're seeing out in the field in terms of the barriers to access to care for patients and their loved ones.
Sure. So, I mean, of course, there are the, beginning with kind of the obvious barriers, right? We know that there are infrastructure barriers. So throughout areas of the city, there has been a phenomenon of redlining over history, and we talk about digital redlining as well. And there are areas where the connectivity and the broadband just isn't great. Now, New York City has worked very hard to address that through the pandemic, and there's a sort of master plan to that's already underway to improve that situation. But so I'd say one category of barriers is that those kind of hard infrastructure barriers, including broadband. Another piece of hardware infrastructure would be devices and the actual tablets and or other tools to connect physically. But the bigger barriers that we've learned about are those that are that have to do with language barriers, cultural barriers, digital literacy, just sort of comfort with connecting to care in general, and then specifically connecting digitally. And in some instances through our work, in particular with the New York State Reimagine Commission, we learned that people often don't even have the sort of safety net. If for example, someone is a senior and doesn't necessarily have connectivity or digital like behavior in their lives already, in some communities, there were extended family members or support systems to facilitate care for a particular group of seniors where others just didn't have that sort of social safety net and community to connect. So those kind of aspects of comfort level inform access as much as, if not more than, the actual physical infrastructure that is lacking in some communities.
And can you talk a little bit, Shoshanah, about your community health workers and how they kind of serve as navigators to make the experience a little bit more seamless for patients and families as they're, going through a telehealth encounter?
Sure. So, I mean, one of the things that community health workers do, AIRnyc community health workers included, is to meet people where they are. And we've heard that phrase a lot, and it is true. So prior to COVID, as I mentioned, we were meeting people in person in kitchens and living rooms and apartments and community settings. We've tried to approximate that virtually. And what we do is we lead with the goal of building trust. And so and that can happen in many ways. One of the ways it happens is the way we speak to people. We speak to people with humility. We focus on that trust building first to try to understand what the person's priorities and needs are, because they may be different from that, from the view of the physician or the view of an administrator at a school or elsewhere, other kind of authority. So we listen, we approach with humility, we try to assess the person's kind of needs, including their digital needs and their kind of willingness to connect or learn about modalities that they may not have taken advantage of in the past. So the community health worker, in the work that we did, for example, in partnership with Mount Sinai Health Partners, we had a brief assessment that quickly offered the choice of telehealth to a patient. In this particular project, we focused on NYSHealth residents who had more than one chronic condition and also were sort of screened for high social needs and and deferred care needs. So the community health worker, in the appropriate language with the appropriate kind of tools to connect interpersonally, would find out what the person wanted to do, whether they were aware of this particular health system's different offerings in telehealth, and those have evolved in the last year. So there were, urgent care visits, there were, other kinds of ways of connecting by phone. There were some types of telehealth that then allowed somebody to quickly get to an in-person visit if they needed that. And the community health worker's role was really, as you said, to help navigate. So in some cases, people needed just that extra support because initially the tech tools and the platforms and the portals were all in English, and later were translated into other languages, including Spanish in this particular zone of the city. There are sometimes barriers where somebody needed to have an email address, and we know that the population we serve is very digital through smartphone use, texting, other instant messaging platforms, but not necessarily email users. So that became a certain barrier that a community health worker could work through with a person. Same thing with other requirements prior to COVID that have since, in some cases been addressed. Sometimes people needed a particular activation code. There were all kinds of sort of those technical issues that a digital navigator is well positioned to help somebody address and walk through with them, either synchronously or asynchronously, or possibly through a repeated follow-up call. Perhaps somebody wasn't ready initially to connect with a provider through telehealth, but then upon a follow-up express the desire to do so. So it's showing up and staying present in somebody's life, especially for vulnerable people who are managing so many things. And that was true before COVID.
Absolutely. Can you share a little bit on how you created this model so that it was truly responsive to the needs of, the patients and families that you serve? So how you kind of involved patients in developing like what this framework would look like?
Yeah, I mean, I think to a large extent, it has evolved and grown out of the work that we've been doing. At AIRnyc for a long time. So, it's always kind of trying to begin with an assessment and begin with the kind of level setting of a person's social needs and social context being as important as any type of care plan or treatment plan or medical recommendation. And so, when you begin conversations that way and you try to engage people that way, whether it's around food or transportation or childcare or these other barriers that interfere with a person's ability to connect with healthcare delivery, the relationship grows out of that. So, again, early in the pandemic, we had a health system partner who very quickly stood up a hotline, and this was a safety net system. And our community health worker was able to quickly connect somebody to a particular provider at a safety net on the phone. Now that's a very low tech solution, but it's something that wasn't available before COVID. And for us, that's telehealth. I mean, it doesn't need to necessarily be a video modality. On video, we learned that we can do all kinds of things, and it's very helpful to be able to look at somebody's face, to be able to interpret body language. When we have video, it's terrific, but not everybody's comfortable with video, and not everybody has video. So that's kind of listening and doing this sort of informal or early surveying with our patients. As we flipped to a digital remote model, we learned that people often didn't want to be on camera. They told us they didn't want to, their hair wasn't done, or their apartment maybe wasn't in the state of camera readiness like mine right now, which is why I have this background on. So I think we have to be sensitive to what we're hearing, and we can't impose a video modality when that's not appropriate, at the expense of not connecting with somebody, where if patient engagement is our goal, and bringing people into care is our goal. So I think, in general, we bring a perspective of listening to the people we serve, listening to our community partners who operate in different spheres of the sort of social service sector. There's just been a lot of learning in this last period for all of us.
Great, thanks. I'm going to go ahead and transition, if you're okay, over to some Q&A because we're starting to get some
Sure.
questions. So
Great.
just a reminder to our audience, if you have questions for Shoshanah, please put those in the chat and I will ask those questions to her. So the first question, Shoshanah, is someone wanted to know if you would clarify how the community health workers connect with patients. So are they doing that via telephone, or do they make home visits? Did they or will they in the future?
Yes. So prior to COVID, we were strictly an in-person home visiting program. Since COVID, as I mentioned, we've been working remotely for the safety of our staff, for the comfort of and safety of the people we serve. Increasingly, we are exploring a return to in-person work that will probably be a modified kind of way of meeting people, again, leading with their preferences. So, for one of the first places we'll return is through some of our community work, perhaps in a school setting or through a clinic, where we'll meet people there in environments that can be well controlled for safety, as this virus is not over. Interestingly, what we and many others have learned through the pandemic is that we've been able to accomplish a ton working remotely. We've been able to reach many more people with much more frequency. And we have found that we have not really seen a decline in our ability to engage with people. We have not seen a decline in our ability to support our staff. And in fact, with our kind of multiple huddles, teamwork, case review, just kind of really judiciously supporting our community health worker team to do this work. We've been able to do it in much more kind of robust ways remotely. So some hybrid model will be our strategy going forward, as we don't believe that everybody's ready for an in-person home visit yet.
Got it. Thank you. And how do you involve caregivers, so families, friends, in the CHW visits? If you do, how do you include them?
That's a great question, with particular relevance to telehealth. So, prior to COVID, when we were in person, it was much easier to bring in a grandmother, to bring in other relatives or social contacts of somebody who happened to be around, and kind of naturally let those conversations happen and those relationships build. That's harder online. I think when, we again lead with the choice of the patient we're serving. So if a patient requests that we speak to a caregiver, a relative, a child, a parent, we do that. It's a little trickier working remotely, but one of the kind of beautiful things about telehealth is that we're able to encourage somebody who may not feel comfortable to invite somebody else in their trusted world to join a visit, and have that person on site facilitating either the technical issues of connecting, or in some cases interpretation where medical interpreters are not available. I mean, one of the things I wanted to hit on is, for just in case there are any kind of provider organizations or systems thinking about this work, I know everybody's in different stages of really addressing telehealth equity. But one of the things that we can absolutely recommend is that health systems really think about, what does it mean to have an equity based approach to facilitation to telehealth for your patient? So for example, leaving extra time to prepare somebody for a telehealth visit, investing in the support staff to do that, because we know a physician can't spend their time doing tech support, but we know that telehealth works better for somebody who's on the other side of the digital divide. If you can have that lead time, make sure that everything is teed up and primed for the patient when they step into the virtual visit, so that the clinician can focus on the clinical aspects of providing care. That's one thing. Making sure that there are, again, qualified medical interpreters to join a telehealth visit for when language is a barrier. Making sure that there are closed captions or other kinds of enlarged text capabilities. All of the things that we've all learned about health literacy and working with populations with low health literacy, which are different from people with low English proficiency. What we need to do is make sure that we have our materials, our orientation materials set up with images. Thinking about the level of health literacy on your sites is important. And just making sure that staff who may otherwise not have had training in cultural humility, some people are still calling competence, I prefer humility, that people who haven't had training in working with underserved populations, in working with people with disabilities, in working with people who do not trust the system. If you're the front end on the system facilitating those telehealth visits, it's really important that your staff has training in those aspects of building trust, because that will be ultimately what enables a productive telehealth visit for somebody who may not have tried it before.
Absolutely. Absolutely. Thank you. So we have a question about medical insurance and really pushing for video visits versus, a telephone visit, and that they're no longer allowing telephone visits. So can you clarify if what your understanding is of?
I mean, to be honest, the regulatory challenges around reimbursement rates for providers, that is like a whole nother can of worms. And the business interests and incentives that are driving those things are not what I want to focus on, because it's evolving. I don't think it's clear. I think it's different for sort of a safety net FQHC than it is for a tech startup, than it is for a healthcare delivery system. So, I mean, where I focus is really on kind of the other side of that. How do we make sure that people without insurance, that people who are underinsured, that people who are afraid to connect or unable or unwilling today, how can we motivate, inspire, challenge people, find ways of bridging those gaps? I believe that reimbursement should be set up in a way that enables care from nobody will be surprised to hear this, but from the perspective of improving a health outcome rather than people being able to extract value or be paid disproportionately or out of scale with the service unit that they're delivering. So I'm absolutely for telehealth, and I'm for all of the modalities that make it easier for people to avail themselves of the help and the care for the specific use cases where that makes sense. So I do not think that telehealth can solve all of our problems. There are healthcare needs that people need to get into person care to solve. But there are quite a lot of situations where telehealth pathways should be opened up as one means of increasing health equity, of expanding access, because of the very obvious ways that they reduce barriers and address social determinants. And those are well known. You don't need childcare to have a telehealth visit. You don't need to get on a public transportation to have a to have a telehealth visit. So all of those things, you don't have to maybe take off as much time for work. Those are all aspects of increasing access to care that I support.
Thank you. I just wanted to add, someone included in the chat that the State Department of Health just published regulations saying that audio only for patients on Medicaid would be permanent. So just to follow up to that.
Yes.
We have a question about what do you see in the field being done for patients that are deaf or hard of hearing in terms of closed captioning and making sure that, the interaction is in sync with, the captioning so that the patient can follow along with the doctor or care team member?
Right. I think that there are some federal regulations HHS has put out about, through the ADA or other aspects of access and equitable access to populations, including differently abled people, that we should all follow. I think those are not enforced. I think those are not consistent. I think we have a long way to go. But I am starting to see that surface as the kind of the best practice and the standard.
Okay. And then the next question we have in the chat is sounds like wanting your opinion on whether or not payment parity is an issue that needs to be resolved in order to make providers more willing to participate in telehealth in New York.
I mean, I think resolving that would be terrific. I don't think I think there's no sort of silver bullet here. I mean, the same kind of issues of disparities, inequities surrounding health, healthcare, social care, we carry forward into telehealth. So I think that, you know, behavioral health, mental health, the head is connected to the body. You know, the providers are in clinical settings. We just need to connect a bunch of things that we know how to do already, and not sort of hide behind these various, you know, songs and dances about return on investment, and just do the right thing. I mean, I know that's easier to say than do, but we have the technology. You know, broadband, make it a utility. Let's not just replicate all of this inequity that we know doesn't work for us in this country, the state, the city. So that's what I have to say about that.
Someone is asking, so you spoke quite a bit about some of the barriers to telehealth earlier in terms of access. What are some strategies an organization can implement to kind of overcome some of those barriers to access?
Is the question coming from, you know, from the healthcare delivery perspective, or just general organizations? Okay, so I mean, I think I mentioned some of those strategies, making sure things are in appropriate language at the appropriate level, making sure there are multiple sort of channels and modalities, making it very easy to press a button and connect to the provider. You know, some of the, I'm not going to speak to any specific vendor, you know, one over another, but I think that we all recognize the plug and play technology when we see it, and we should absolutely opt for that every time we can, so that a person doesn't have to go through unnecessary hoops to connect with a provider. But I think the idea of really taking seriously that prep time piece is important. I was able in the early days of the pandemic to observe my wife, who's a clinician taking care of sickle cell patients. And she worked in several different hospitals, and in the hospitals where that prep happened, the visit went through beautifully, and people are absolutely able to connect. If the physician is left to kind of scramble to see if somebody's phone is working, somebody can, you know, has to do all of that prep work, it's not going to happen. So I really think that we need to invest in all of that planning and prep to queue somebody up to be able to connect on both sides.
Great, thank you. And I just want to get to, I know we're almost at time, but one last question. Do you have any concerns about telehealth services not being covered under any other circumstances that you haven't addressed today?
I mean, I think we need a lot more mental health care, access to affordable mental health care for people. And you know, there is some kind of awareness in this country now that we all could benefit from more care there. I think, again, for people who don't have insurance, for people who you know, can't necessarily easily connect, we just need more resources there. You know, I think there are, if you look at the amount of venture capital money pouring into kind of applications and the digital health space, I think that's a reflection of what we can do, what we can pay for. And I think that we have to play catch up to make sure that all of these wonderful technologies are also available for everybody.
Great. Well, thank you so much, Shoshanah. I'm just very appreciative of your time and you sharing your expertise and insights with us today. And thank you to everyone that joined our webinar. As a reminder, the recording of this webinar will be sent after this. Please follow us on Twitter at NYS_health, or go to our website to sign up for our e-newsletters to learn more about upcoming webinars and other resources. Thank you again, everyone. Have a wonderful afternoon.
Thanks, Mikhail.